All right. Hello, everybody. I'm Austin Chen. I'm one of the internal medicine chief residents at the Mont Lake site. Thanks all for coming to the Department of Medicine grand rounds, both in person and the folks on Zoom. Um, we are really hoping to increase turnout in person. So if you're in the building, please come over and watch. I know it's tempting to watch on Zoom, but we're friendly and we like seeing you in person. And food is allowed in this auditorium, so feel free to bring your lunch. Um, and today I have the pleasure of introducing Dr. Reena Mehra. She is our division head of pulmonary critical care and sleep medicine. And Dr. Mehra is internationally recognized for her expertise in sleep disorders and health outcomes, including cardiopulmonary and neurologic disease. Her research focuses on the investigation of pathways which modulate the relationship between sleep disordered breathing and abnormal cardiac electrophysiology, as well as cardiovascular disease in clinical trials and epidemiological studies. She has served as, and this is a very long list, associate editor of the Chest Journal, an associate editor of the American Journal of Respiratory and Critical Care Medicine, the chair of the planning committee of the American Thoracic Society Sleep Respiratory Neurobiology Assembly, the chair of the American Academy of Sleep Medicine Inpatient Diagnostic Sleep Testing Task Force, the chair of the American Heart Association Statement on Sleep Apnea and Cardiac Arrhythmia, a co-chair of the National Heart, Lung, and Blood Institute's Autonomic Nervous System Cardiopulmonary Interactions Workshop, the president of the Women Faculty School of Medicine of the Case School of Medicine, and the chair of the Presidential Task Force of the Young Physicians of the American Academy of Sleep Medicine. So in addition to all of these accomplishments, she has also mentored more than 40 trainees and has a passion for team building, mentorship, and is an advocate for the advancement of women in medicine. Her talk today is titled Reflections on a Journey of Purpose, Persistence, and Possibility in Academic Medicine. Please welcome Dr. Reena Mehra.
Wow, I don't know where you got the introduction from, but that's thank you so much. That was very, very kind. And very detailed. So I appreciate it, Austin. That's great and welcome and congratulations for matching in the fellowship with us. And I should have had you play a little prelude on your saxophone beforehand here. So, and thanks to everyone for joining in person, and thanks to those joining online as well. So this will be the last grand rounds of 2025, and it's been quite a challenging year. And the word of the year, I think, is uncertainty, and certainly also, just a state of feeling unsettled. Yet we have all persevered. I wanted to just share that I had some challenges with figuring out what to talk about today and how to structure the presentation. And so as I gave it some thought and really now almost 2 years into my role as division head, I have really come to appreciate the community here at University of Washington and the mission and the values and the shared sense of learning, again, the strong community and the thoughtful reflection. And usually my presentations are about the science or about mentorship or about leadership. And I wanted this one to be a bit different, to provide that context. And when I say context, I mean the experience, inflection points in career, and the relationships that you build along the way, because that's really the essence of the journey. And in particular, I thought it would be helpful to frame it this way for our early career folks, our learners, our trainees, students, residents, fellows, and also early career faculty, who are, scientists or early budding scientists, clinicians, educators. It's a time of, that's really exciting, but it can also be very overwhelming and hard to see the path forward. And we just had some conversations recently with some early career folks, and it's hard to make decisions about something you can't quite see. So in the event that this is helpful from that standpoint and can help as folks are going along their career trajectories, I thought I would structure it as kind of more of a story of my professional journey and my personal journey as well. So, and with that, we'll go ahead and get started. So I do have these disclosures, but really they don't have anything specific as it pertains to this talk. So I'll start off by sharing some of my background and then this sort of interwoven tapestry of my paths of personal and professional life. And I'll kind of toggle back and forth between the science and also the kind of personal anecdotes. And then landing here at University of Washington, which has been very fortuitous and incredibly rewarding, in large part because of the people I get to work with. Um, Sharing some guiding philosophy and lessons learned. And then at the end, I'll just share some final thoughts. So I grew up in Youngstown, Ohio. I'm the daughter of two Indian immigrants. My father came over in the 1960s on a boat to attend SUNY Buffalo and get his PhD in economics. He went back to India, married my mother. They had an arranged marriage, brought her back to the United States, and then he had the option to go to Juneau, Alaska, or Youngstown, Ohio, and he chose Youngstown, Ohio. So Youngstown's an old steel mill town. Oh, yeah, Amy's shaking her head. I'm sorry, Amy. An old steel mill town. Mafia presence is pretty strong. I had nothing to do with that. And my father's father actually was an English professor. My mother's mother actually was a principal of a college in India and had 4 master's degrees, which was something quite unusual for a woman of that time. My uncle is a chemist, and he had a patent to do with RNA isolation, and in part, kind of set the stage for some of the COVID vaccines that we use today. My mother raised my sister and I to be independent, especially financially independent. My sister is actually an intellectual properties lawyer, a litigation lawyer. And so we had a non-physician family pretty much, which is atypical for an Indian family. I was the only Asian of more than 550 graduating students from my high school, and less than 2% were underrepresented minorities. And so although there weren't physicians in my family and the community, I was fortunate to interact with friends of our family who were physicians, and they really shaped my interest in medicine. So I applied for a BSMD combined 6-year program, formerly known as NEO-UCOM and now NeoMed, and that kind of shaped my early professional identity. If you ever find yourself in Youngstown, I highly recommend Wedgwood Pizza. And if you go for ice cream, Handel's ice cream, the butter pecan is the best. There's this historical landmark called the Old Lanterman's Mill. It was built before the Civil War in the 1840s and continues to actually grind corn and grain and buckwheat grain. Youngstown is equidistant from Pittsburgh and Cleveland, relatively speaking. So I grew up a Steelers fan. So I didn't let the folks in Cleveland, I didn't advertise that too widely. In terms of other personal life milestones, I met my husband to be Tom Gilday during our pulmonary and critical care fellowship at the Cleveland Clinic. He has built the largest program in the world, really, of interventional pulmonary at the Cleveland Clinic. Now has taken another position with Olympus. He and I met. I was pretty convinced he was going to be a snob. So as a second-year fellow responsible for making the schedule, I put him on call for virtually every holiday, and then ended up liking him. So it completely backfired on me. But we got married in 2005. So it was a melding of two different cultures. He comes from Irish Welsh background. So we had a Hindu ceremony, we had an Episcopalian ceremony as well. And much to Tom's chagrin, he wanted a small wedding, but I told him, you're marrying an Indian woman. And my mother had a list of 200 alone. So our wedding had over 400 folks there. I don't have a middle name, so our children have middle names. So we have Rohan Robert and Dahlia Grace. Our holiday cards would feature the kids' antics, and we have Marco is our dog, and Enzo unfortunately passed a couple months ago, and now our daughter is heavily lobbying for a puppy. She has essentially given us a PowerPoint presentation and drawn up a contract, and Tom and I have signed it, so it's pretty much a foregone conclusion at this point. She's very persistent. We really enjoyed Seattle. Snoqualmie Falls looks very different right now, of course, but really had some really wonderful times. So from medical school, went on to internal medicine residency at Loyola University Medical Center, and there had the opportunity to work with Martin Tobin. So Martin Tobin is really a very no-nonsense person and a trailblazer in the field of ICU medicine, developing the rapid shallow breathing index, which is a weaning parameter used to liberate from mechanical ventilation. Many may know him from the recent George Floyd trial, where he described the compression on the hypopharynx and asphyxiation. He has been the editor-in-chief of the Blue Journal, and really has, during his time as editor, really just was really for conciseness and brevity and clearness of messaging with the submissions to the journal. Kevin Simpson was our pulmonologist, our program director, and Pat Fahey was pretty relentless on rounds in terms of grilling us on remote and obscure facts on pulmonary physiology, such as the mitochondrial partial pressure of oxygen, which is 2, by the way. I went on to then pursue pulmonary and critical care and sleep medicine fellowship at the Cleveland Clinic, a pretty intense clinical training model there. And during my fellowship, was interested in research. And so I aligned with Dr. Janet Maurer, who was the director of lung transplantation, and designed a trial to address hypogammaglobulinemia in lung transplant patients by using IVIG versus placebo in a small randomized trial. And then unfortunately, during the midst of my fellowship, she ended up leaving. And so I kind of didn't have the mentorship that I really needed to pursue research. So I was kind of left a bit wanting in that regard. I did develop an interest in sleep medicine. So during that time, you could use your elective time to hang out with the sleep medicine specialists, and the fellows, either gravitated towards it, or like my husband went the opposite direction into interventional pulmonary. But that's where my interest and focus really began in sleep medicine. And Herb Wiedemann was our chair of pulmonary critical care medicine, later to be chief of staff, was very involved in the ARDSNet trials, and actually did his residency and chief resident year here at University of Washington from 1977 to 1981. So as I approached the end of my fellowship, I talked to Herb. He said, you have a position here to stay on as a faculty doing clinical work in pulmonary critical care and sleep medicine. And then a couple of months prior to the end of my fellowship, Herb ran into Kingman Stroll in the airport. And Kingman Stroll is a sleep medicine respiratory physiologist. He is the PI of a T32 sleep medicine neurobiology and epidemiology training grant. And he says to Herb, I have an open spot on this T32. Do you happen to know someone? And Herb said, actually, as a matter of fact, I do. So when Herb returned from his trip, he reached out to me and said, you should look into this opportunity. It was 2 months before I was supposed to end my fellowship. And so I went to go visit with Kingman, and he's a very creative thinker. I tend to be linear. He's a very creative thinker and really got me excited about sleep medicine research. And so I decided to join the fellowship. So that airport conversation was a serendipitous kind of chance encounter that kind of really changed my career trajectory. During my T32 fellowship, I was fortunate to have Susan Redline, who is a trailblazer in the field of sleep medicine epidemiology, was PI of a reading center for many multi-center epidemiologic studies, so got connected to that, and then also to writing groups, to investigators around the country, and then I was able to refine my scientific writing through those connections as well. I have here as well I am no domestic goddess, so we would not infrequently order food, and my son got to know the delivery man quite well, and so he received this fortune that said, the one who snores will always fall asleep first. So I think that was a good omen that I was going on the right path with my career in sleep medicine. So I joined on as faculty after the T32 at University Hospitals Case Western Reserve University. And during this transition, I was applying for my first grant, so a K23 Career Development Award. And that was back in the day where you could apply 3 times. So with the first application, the reviewers said I was overly ambitious because I was proposing my own independent clinical trial separate from my mentor. It's the kiss of death. And I was like, oh no. So I went in the second time and I went the opposite direction and proposed a study that was directly embedded in my mentor's study. And then I learned from the first time. I, before reading the comments, had a glass of wine, read the comments, and then they said I basically wasn't independent enough. So the third time, I'm like, okay, well, I proposed again the independent trial, but then I said, I tried to reassure them that I would be getting mentorship and guidance through my mentor and my mentorship team. And I also then thought, well, I better apply to some other mechanisms as well. So I applied to our institutional KL2, an American Heart Association Scientist Development Grant, and a CHEST Award. And lo and behold, they were all funded. And fortunately, I was able to keep the AHA and CHEST awards because there was enough separateness and there wasn't as much scientific overlap. And so I have to say, looking back at that time, it was very hard to face the rejection, but I was around people, my mentors and my peers, and there was a community there for supporting as I was going through it. So that is really what helped keep me going. I really like this map. This is the island of research, and I think it brings some levity to the process of being a scientist because of all the challenges. So I have been to many places on this island, such as the Canyon of Despair, the Fundless Desert. I quite like the data analysis jungle, the bog of manuscripts. So this helps me deal sometimes if I'm finding myself getting frustrated with some of the rejection that just is part of the territory with the path of being a scientist. And so you may ask, why sleep medicine? Well, sleep medicine is a relatively young discipline, and there's a lot that we still don't know. So we're just scratching the surface in terms of our knowledge. And sleep and circadian rhythm, they're, interacting networks that regulate, feeding, social interactions, physical activity. We have process S and process C. Process S is when there's, there's actually increased adenosine. Caffeine's adenosine antagonist that makes you more somnogenic during the day, counteracted by process C. And in terms of the circadian rhythm, the diurnal light dark cycles from the Earth's rotation are responsible for our circadian rhythms in mammals. And these are orchestrated by circadian clocks. And so there's a hierarchical structure to that. So the suprachiasmatic nucleus has the master clock, and our tissue and cells contain peripheral clocks. And there's a self-regulatory feedback loops that are involved with those clocks. And if those are disrupted, then that actually can lead to disease formation and progression. It's been recognized now by the American Heart Association of the importance of sleep. So sleep is now represented as one of life's essential 8. And this is important because sleep deprivation is pretty common in the United States. Only 31% of adults are achieving the amount of sleep that they should be getting, which is 7 to 8 hours of sleep. If you look at the map of the United States, in Washington, actually, we're not doing so bad. So we're compared to other areas of the country. There have been some key breakthroughs in sleep medicine as well, with investigators who have been responsible for elucidating the molecular underpinnings of the circadian rhythm, and in 2017, and then hypoxic sensing mechanisms such as with HIP-1 alpha, which is relevant, directly relevant to the intermittent hypoxia that is as part of the pathophysiology of obstructive sleep apnea and sleep disordered breathing. So sleep and circadian rhythm disorders really require the management and approach to it require a multidisciplinary approach. And that's one of the things that I find really appealing. And also one of the reasons why I really like team science. I like getting diverse perspectives together to help treat our patients or develop something new. And interdisciplinary collaborations are also very important. There are over 90 sleep and circadian rhythm disorders, and some of them are actually quite prevalent. They lead to a lot of disruption, metabolic dysregulation, upregulation of systemic inflammation, oxidative stress, autonomic fluctuations. So there's direct kind of impact on our physiology. And it has negative impacts on our quality of life, daytime sleepiness, fatigue, some catastrophic accidents such as Exxon Valdez oil spill, Chernobyl are attributable to individuals that weren't getting enough sleep. Motor vehicle accidents, drowsy driving, and also can lead to adverse health consequences. So neurocognitive, cardiopulmonary, increased mortality. These disorders really have far-reaching impact on our well-being and our health. And it is aptly termed that sleep is that golden chain that ties health and our bodies together. And in terms of obstructive sleep apnea, so this is one of the areas that I've been focused on most in my research. It's highly prevalent, it's under-recognized, and it's a physiologic stressor. And not only is it a nocturnal physiologic stressor, the ramifications pathophysiologically of sleep apnea carry through during the day and can have effects on our health. It afflicts nearly 1 billion people worldwide. Nearly 1 in 15 are affected by at least a moderate degree of obstructive sleep apnea. And per data from Dr. Kapoor, Vishesh Kapoor, from the Sleep Heart Health Study, he found that about 85% of individuals presenting for that study, of which there were nearly 6,000 participants, were estimated to be undiagnosed. And then a decade later, still 80 to 90% of individuals with moderate to severe degree sleep apnea in the multi-ethnic study of atherosclerosis were identified to be not diagnosed. And underrepresented minorities were more vulnerable to this underdiagnosis. Taking a different stance, we looked at claims data, insurance claims data involving nearly 65 million individuals, and found that OSA prevalence was actually increasing during the period of time of the study. And this paralleled an increase in home sleep apnea testing and a slight reduction in polysomnography. So that increase in home sleep apnea testing is allowing us to have a positive impact in terms of accessibility for diagnosis of sleep apnea. So this is one of the first studies I conducted as a T32 fellow. We were looking at serious adverse events during polysomnography. And there were over 16,000 patients across 5 different sites. And this is one of the patients. This is a 61-year-old obese male, history of coronary artery disease, cardiomyopathy, underwent a split night study where the first part is diagnostic and the latter portion was a titration study to identify the optimal pressure to treat sleep apnea. And sleep apnea was suspected on the basis of snoring and witness pauses. So about 45 minutes prior to the end of the study, and again, 30 minutes prior to the end of the study, there were these episodes of polymorphic non-sustained ventricular tachycardia. At the end of the study, ventricular fibrillation and this torsades appearance. So this sleep lab was actually in a hospital facility. A code was called, and unfortunately, this patient died during the sleep study. So this really was a very formative event and catalyzed my interest in understanding the relationship of sleep apnea and cardiac arrhythmias. In particular, how long was this patient not diagnosed and not treated, where there could have been, cardiac structural and electrophysiologic remodeling that then led to this increased risk for cardiac arrhythmias. So since I had mentorship through Susan Redline, she had access to these multi-center epidemiologic cohorts. We decided to look at this more closely in the Sleep Heart Health Study. So we were looking at atrial and ventricular tachycardia arrhythmias. And I, pored over the sleep studies along with the technologists to score the data. And we compared those with severe sleep apnea compared to those without sleep apnea. We group matched those 2 groups, and then we also adjusted for potential confounders, including obesity, cardiovascular risk factors, and cardiovascular outcomes as well. And the magnitude of association was pretty surprising to us, about a 2 to 5-fold higher odds of having these arrhythmias in severe sleep apnea compared to those without. So this is some of the first epidemiologic evidence noting an association. We then went on to try to see what are the relationships if we consider sleep apnea as a continuum. And we found that with increasing severity of sleep apnea, there was increased burden of both atrial fibrillation and complex ventricular ectopy in this multi-center cohort of older men, approximately 3,000 of them. So these monotonic relationships that were observed. And then we decided to look at things longitudinally, and interestingly found in two independent cohorts, one work led by Dr. Anna May, that central sleep apnea was actually predictive of new onset atrial fibrillation over time. And so there was internal consistency with and external validation of the findings from the Sleep Heart Health study to the Outcomes of Sleep Disorders in Older Men study. Dilip Raman was interested in seeing whether these sleep studies, the ECG data from these sleep studies was valuable in predicting outcomes, because most home sleep tests don't include the ECG. And so these tests that were conducted in the Outcomes of Sleep Disorders Older Men study were all done in the home setting and included EKG. And he found that heart rate variability measures, interestingly, increased LF-HF ratio, suggested an increased risk of incident atrial fibrillation over time. And then this relationship was actually modified by obstructive sleep apnea. And we also found that the burden of PACs on that baseline ECG was predictive of also incident atrial fibrillation over time. And we collaborated also with Marie Middleman from now Mass General Brigham to examine the immediate temporal relationships between the apneic and hypopneic events and the discrete arrhythmias, the non-sustained ventricular tachycardia episodes and the paroxysms of atrial fibrillation. And we use this case crossover design, which is commonly used in air pollution studies and of which Dr. Middleman is an expert. And we use a unidirectional design to assess when the discrete episodes of arrhythmia were happening and the hazard periods preceding, and then normal sinus rhythm periods with referent periods, and found there to be a pretty high 18-fold increased risk of discrete nocturnal arrhythmias within 90 seconds following these apneic and hypopneic events. So overall, these data are showing us that there's a strong magnitude of association, there's monotonic relationships, there's temporal relationships over time, and even from an immediate standpoint, and suggesting that there's causality there. In terms of that clinical trial that I had proposed for my K award, we examined those on CPAP versus sham CPAP and identified some improvement in some of these biomarkers of inflammation, namely soluble IL-6 receptor. And Anna May was also interested in looking at sex-specific differences. This is post hoc analysis, not a priori, based on a priori hypotheses. But however, found that women seem to have a greater responsiveness in terms of improvement in some of these biomarkers of paraoxinase, soluble IL-6 receptor, and myeloperoxidase. These findings actually weren't as observed in men. So I'll sidebar a little bit here. So it's some of the early career work. Was able to mentor some individuals as well. And as I was in early career and writing grants, I got interested in the Women Faculty School of Medicine. It's an area that I felt could use some attention, and I wanted to know what was going on that scene. And so as I joined, hopefully this wasn't because of me, participation started to dwindle on our steering committee. And the president of the Women Faculty School of Medicine, she was in the midst of her 2-year term and said, I'm not able to do this anymore. So it was her and the steering committee member, and they looked at me and they said, Reena, do you want to be president of the Women Faculty School of Medicine? I'm assistant professor at the time. And I thought about it. I didn't think too long. And I said yes, because I was excited about this. And I met with my mentor not too soon thereafter, and she was very upset with me. She said, Reena, you really should be focusing on your science. She says, it's going to be a distraction for you. We now laugh about this, and she now says, Reena, well, this was your passion. You should have gone for it. I'm actually glad that you did it. And I'm glad too. It was actually a really rewarding, informative experience for me. So I was based at university hospitals. I reached out to colleagues at the VA, at the Cleveland Clinic, at Metro Health Medical Center, serving our underserved population. And we had cross-institutional representation on the steering committee. And then we developed some programming and leadership development. We had invited speakers, a promotion and tenure workshop. And it was really exciting to kind of address a need and be part of addressing that need. And then as I transitioned off of the role of president, Shamita Khatri, my friend and colleague, took over, and she spearheaded the idea of this Flex program, which is a leadership development coaching program. And so we met with the dean, now Emerita Dean Pam Davis, and we met in her conference room, oval table, steering committee, sitting all around, and we pitched the proposal to her. And we asked for $50,000, and we thought there was no way she was going to give us and fund and to jumpstart this Flex program, but she agreed on the spot. And so learned from that, no harm in asking, especially for something that you are very passionate about. Along those lines, with the Women Faculty School of Medicine, we worked with Dr. Singer, who had a National Science Foundation Award to examine how we can remove barriers for women in academic medicine. And so along those lines, we had Dr. Jaxie, actually, who actually provided a grand rounds a few months ago. And I was a participant actually in one of her studies. So she reached out to K awardees about 20 years ago to assess for gender differences in salary. And it turned out there was, a difference in salary with women earning more than men, and actually found this to be the case in dean suites as well across the country, with even the type of position that women versus men have and the salary that they get. I went to a recent conference, and I found this data to be striking, so I thought I would share it here as well. These are the points in the calendar year where these groups of people can catch up to the same salary as men. And you can see for women overall, it's March 25th. For Black women, July 10th, and Native women, November 18th. So I found these data to be quite striking that, and this is, as of our current state. From a positive standpoint, the national soccer team, the women's soccer team, achieved a landmark victory in 2022, and they were able to secure a settlement that allows them to have equal pay with the men's team. So some areas where we're moving in the right direction. And I really wanted to talk about mentorship as well. This is something that I'm very passionate about. In my career, I have been so grateful to have exceptional mentorship from so many people. It takes a village. I think you get something different from each of these individuals that are in your life. And then also sponsorship. So sponsorship really helps to open unexpected doors. And again, I've been a grateful beneficiary of that. We have Richard Irwin, who is editor-in-chief of the journal Chest, who asked me to serve as associate editor when I was mid-career. And I was wondering, why did he reach out to me? And it turns out that Nancy Collop, who now has just recently retired and was at Emory, she's the one who suggested my name. And so it's that kind of behind the scenes recommendation and connecting that really is also so helpful in careers in addition to mentorship. And so with all of this, I have, strong desire to pay it forward. And the big secret is that that mentoring is I think far more fulfilling than being the mentee. You get to be part of your mentees' lives, their weddings, their having children, and their successes are far more rewarding than your own. And I thought I'd share this too. I didn't know this. So the mentoring in terms of the name, in the Odyssey, Homer's epic poem, it's actually not mentor who fulfills the duty of advisor and guardian to Odysseus' son Telemachus. It is Athena, the goddess of wisdom, who actually takes the form of mentor. And she acts as a catalyst and encourages Telemachus to act, not solving his problems for him, but helping to allow him to realize his full potential. So I thought that was a good tidbit to share. And mentoring is really fulfilling because you can facilitate the change you want to see. So I was fortunate to be part of programs where, where there's outreach and engagement with high school students, with college students. And so the John Hay High School in Cleveland, we had several of those students join our research team and present actually locally. The Case School of Medicine had also a heart, lung, blood, and sleep disorders summer research program. And Alex Sosa, shown here, was actually a physics major. He joined our group and decided to go into medicine, and he's now completing his neurology residency. So those are the experiences that I think are just so remarkable and fulfilling. I was fortunate to develop a mentorship program through the American Academy of Sleep Medicine. This was about 7 years ago, and I'm no longer part of it, but it is still ongoing. And also a mentorship program for the physician scientists at the Cleveland Clinic as well. So as I was building the career at Case and University Hospitals, there came an opportunity at the Cleveland Clinic. So the Cleveland Clinic really had a renowned clinical program, not so much of a footprint in research. And so there was an opportunity to help grow and strengthen that footprint in research at the Cleveland Clinic and the sleep disorders program. So I decided to make the move to go there across the street and work to build and integrate a statistical team within the Sleep Disorders Center, develop a research resource for data, which is one of the largest registries that I'm aware of sleep studies, now up to over 250,000 sleep studies, and also develop a structured mentored program. So these ingredients together, having data, the ability to analyze the data, and mentorship really were key in allowing for support of our fellows and our early career scientists as well, and led to many projects and papers and grants. And some of these I'll share with you. So because we had the registry, it allowed us to nimbly integrate with the COVID registry during the pandemic as well. And so Dr. Pena Orbea decided to look at sleep disordered breathing and how that relates to COVID-19 outcomes, and found that the sleep-related hypoxia in particular was related to increased hospitalizations and death from the time of COVID-19 symptom onset. She also is very interested in health disparities and leveraged the registry to look at area deprivation and major adverse cardiovascular outcomes and how sleep disordered breathing modified this relationship. And she found area deprivation is associated with cardiovascular outcomes, also with sleep apnea, and in particular, again, it's a sleep-related hypoxia that seems to be the effect modifier of this relationship. And so she's working on writing this up. Katie Heinzinger, a T32 scholar, she decided to leverage the registry to look at sleep disordered breathing and atrial fibrillation. So those epidemiologic studies, those were around the order of 3,000 to 6,000. This registry allowed us to tap into, 40,000, over 40,000 patients. And she found that there were relationships with the frequency measure of sleep apnea and hypoxia as it relates to atrial fibrillation. And we actually were able to get some of the pulmonary function testing data as well and adjust for any underlying restrictive obstructive physiology to ensure that that wasn't confounding any of the relationships that we were seeing. So at my time at the Cleveland Clinic, I also got very interested in team science. With looking at a collaboration with IBM through a Discovery Accelerator Award, and I'll share some of those findings. Serving as a reading center for a multi-center study with pulmonary hypertension, and we were able to, for the first time, integrate sleep measures into this multi-center cohort with pulmonary hypertension. Looking at sleep health disparities, as I mentioned, and also sleep and neurodegeneration. So there was a Woman in Alzheimer's Award through Maria Shriver and her foundation. And we were interested, and this work is ongoing, to look at how sleep and circadian rhythm disruption can potentially lead to sex-specific differences in neurocognitive decline as it relates to Alzheimer's disease. So some of these findings, for example, with the PVD-omics study, Sanjeet, Aparna, Megan were able to leverage these data and identify some relationships with sleep apnea and hypoxia with increased right ventricular systolic pressure, reduction in right ventricular ejection fraction, and also worsened survival as well. So again, allowing us to the first time characterize these relationships in pulmonary hypertension. We also leverage the registry to collaborate with our bariatric surgery colleagues to see, well, how does aggressive weight loss translate into any improvement in cardiovascular outcomes in those with obstructive sleep apnea, and found there to be about a 42% reduction in major adverse cardiovascular outcomes. And this was longitudinally over a 10-year period of time. And this was at the same time that the SURMOUNT OSA trial had come out and really showed that tirzepatide was effective in improving sleep apnea. However, the trial was conducted over a span of years, a few years, and wasn't powered to look at major adverse cardiovascular outcomes. So this is suggesting that aggressive weight loss actually does translate into improvement from a cardiovascular standpoint in those with sleep apnea. And then we were able to collaborate with IBM to apply some deep learning models to the multimodal physiologic data that are collected during sleep studies. So with sleep studies clinically, we count the number of times somebody stops breathing divided by the sleep time. We're not really leveraging to the fullest degree all of the rich data that are collected. So this collaboration was an effort to allow us to do that and create, based upon the embeddings from these machine learning algorithms, these clusters, to see if that does a better job than our conventional way of characterizing sleep apnea. And it turns out that it did perform better than the apnea-hypopnea index, and we were able to validate that in another cohort as well. And we used a clinical cohort, and we were able to validate it in an epidemiologic cohort. Also involved with sleep apnea diagnostic and therapeutic innovations. With hypoglossal nerve stimulation serving as an alternative to CPAP for those with severe sleep apnea who are not obese. We were part of the ADHERE multinational registry as well. We're able to identify predictors of responsiveness of hypoglossal nerve stimulation. So actually women tend to have enhanced responsivity compared to men. We found that actually increasing age, it may be something to do with the alterations in connective tissue and anatomy that occurs with aging, that actually they did better in terms of having improvement in the degree of sleep apnea. Looked at some novel therapeutics as well. And Dr. Walia was also very interested in looking at seeing how we can improve adherence with CPAP, motivational enhancement, or other sorts of interventions that can improve our standard treatment with continuous positive airway pressure. So that's some of the science that was going on. And along the way, you're asked to serve on committees, you're asked to contribute, locally. And so it gets kind of challenging to figure out what you should say yes or no to. So my mentor gave me this excitometer, and I used to have it next to my computer. And now I just have it in my mind. So when I'm asked to do something, I say, okay, well, how excited am I to do this? How long is it going to take me to do this? And then I try to make my decisions based on that. And I don't pretend to be very good at this, but I do try to do that. So I'll share some of those experiences with you, some that I liked and some that I kind of didn't like, and you learn from that. So I really enjoyed serving as chair of the SRN Assembly of ATS because there are many groups and committees that were working on programming. We have Dr. Billings and Donovan who are in our division, actually, who were working on guidelines. Luke Donovan actually led the early career working group. And this was also during the time of the pandemic. And so actually we had these meetings, happy hours with seasoned investigators and early career investigators that were virtual, and an opportunity for early career investigators to ask questions of more seasoned investigators. So really trying to keep that connection going during a time where maintaining that connection was difficult. Part of some of the work to, we have identified these associations with sleep apnea and cardiac arrhythmias, and there appears to be causality. So provided the first statement to describe that, and provided also a stepped model to guide us in terms of how to diagnose and manage sleep apnea in those with cardiac arrhythmias. And then an NIH workshop where we really tried to include sleep and circadian rhythm where it hadn't been included before in the whole paradigm of autonomic dysfunction and cardiopulmonary regulation. And just like with most things, we had really wonderful opportunities to interact with these really incredibly brilliant investigators, including Shiv Kalyanam from UCLA. I was also a co-editor of a textbook, and we assembled cases, wrote these chapters, and I hope it's a good resource. However, that's not something I really enjoyed. So if I'm asked to edit a textbook again, I probably will not say yes to it. And so that's just an example of something that you kind of find along the way. So we have some research projects that are underway here at University of Washington, thankfully to Lisa Batten, who's here in the audience, research coordinator, and an N of 1 clinical trial that will be starting up, a dual site clinical trial. So we had started at the Cleveland Clinic. We'll do a dual site trial and using an N of 1 design, and continuing some of the PBD-omics work to with some of the omics signatures to see how that relates with sleep apnea and RV dysfunction in pulmonary arterial hypertension. Alice and Akeda are one of our sleep medicine fellows and wrote a review, and Young Swan Chen also helped us. She's a visiting observer from Taiwan, write a review on therapeutics for obstructive sleep apnea in terms of pharmacologics. And there's some evidence that aldosterone synthase inhibition may be actually a benefit. And we're involved with the phase 2 Explore OSA trial that's nearing completion. So I'll shift now in terms of landing here at University of Washington. So I started in March of 2024. This has been just an incredible, energizing, rewarding, fulfilling experience. And I'll note that it's our 60th anniversary of our division. It was founded in 1965 by John Butler. We have 227 faculty, fellows, researchers, advanced practice providers, and staff. Fortunately, had renewal of our T32 award, which has been continuously funded for 45 years. So that was just renewed effective January of this year. Across many sites. And we have centers as well, Center of Lung Biology led by Dr. Altemeyer, the Cambia Palliative Care Center of Excellence with Dr. Cross, the Center of Interstitial Lung Disease with Dr. Raghu, and the Sepsis Center for Research Excellence by Dr. Badraju, with Dr. Lyles handing over the baton just recently. And the T32 mentors are really dedicated to mentorship. And actually, that's one of the reasons I was really attracted to our division, because mentorship is really part of the fabric of our division. So my guiding philosophy, and hopefully it shows, I try to show up with kindness, respect, and humility, thinking big in terms of science and systems. It's really teamwork that makes it happen. And so having a team of teams that help to bring forward our priorities. It's really also persistence over perfection. So really moving forward with the things we want to do and believe in, collaboration, transparency. I've really, tried to make sure that we're, clear. Emily and I, our division administrator, to be clear in terms of, the directions that we're going, and now developing a strategic plan that we're currently refining, and being authentic. So when I first joined, had multiple group meetings, virtual and in person. It was an effort to get to know folks, and that was so enjoyable. And what I noticed about the virtual meetings was that people were online and they would share about themselves, and I would see the smiles on everyone else's faces as people were talking about their families and their pets. And so really, as you all know, a great sense of community. And found that there's really, really a pipeline of scientists here through the T32 educational programs, clinical programs that are really strong. And I call it the division, and actually University of Washington, kind of this weedy spice garden. There's so many treasures and so many areas that maybe aren't completely obvious, but you kind of find them as you go along. And we have had a lot of changes in our leadership and also in our division, and we are working to try to continue to have a good cohesion. Dawn Hill is our administrative assistant and really is the glue that kind of helps us keep things together. She leads our social committee as well. So at the New Year, New Beginnings, we celebrated Sean Scarrett and Mark Tonelli, who were section heads, and we also celebrated this year Rob Glennie and Monica Fothrop, who have given decades of their time to the division. And so we have leadership change. We have Owen West and Sid Kapnatic as our section heads, Emily Lamont as our division administrator. We have the coronation of Rebecca Sell by Bashak Charu, who our beloved Bashak Charu, and Eric Morel, who's taken on a new role as associate program director to liaise with our T32 and really move forward some of the initiatives for our early career investigators. So I'm really grateful. Everyone has their own superpowers that they bring to the table. It's really fun. And I'm grateful for their commitment and their transparency and approach. I also want to say we talk about leadership, and leadership actually comes in different forms. It's not positional only, relational leadership, expertise. We are all have ways that we can contribute in this regard. As a division, we have tried to identify areas of priorities, and we're kind of use this as a guide in terms of focusing first on low-hanging fruit, low effort, high value priorities, and then also having on our chart high effort, high value, but recognizing that that's a longer timeline to achieve. So our first division retreat, I love the photos, so I thought I would share them. So we have our interstitial lung disease group. We have the Montlake crew, the Harborview crew. We have some of the women in our division as well. And then the Center of Lung Biology. We have the VA crew, and of course the obligatory photo for our sleep medicine group as well. I'm really just so inspired by our faculty and their representation at national conferences from an educational standpoint, a scientific standpoint, and there's a great sense of community with that. We also realized that people didn't know what was going on with their colleagues and what they were doing, and so we started the State of the Division program update series, which allows us to kind of stay connected and understand the latest of what's going on, say, in cystic fibrosis or ICUs or palliative care medicine. And so I think that has been going well. We've started some committees as well, the scientific, educational, and clinical advisory steering committees, and I'm grateful for the leadership of Dr. Altermeyer, Dr. Lux, and Dr. Mack in those regards, and so we're continuing to make strides in those areas. Revamping our website a little bit to more accurately reflect what's going on. Eric Morel's worked really hard to do that, and I'm thankful for that. So we've had several wins with the T32. We're looking for an interventional pulmonologist to direct our program, infrastructure development that's underway. Grants are coming in, early career scientists that are getting funded. We've had 3K awardees, 2K award equivalents, and we're partnering with advancement to really move things forward. So my lessons learned as a division head: respect the process, bring our stakeholders along with decision making, alignment of leadership. There's really power of an engaged and committed community, which we are so fortunate to have. And I really just truly enjoy working with everyone. I find it so energizing. Lessons learned just in general, and in particular for our early career physicians. So a solid support structure is important. It's going to change along the years, but it's really important to allow you to be able to do what you want to do. Keep the faith. So, at times it can be hard, but, lean on your community to help you get through things, maintaining an open perspective to opportunity. Sometimes we have a clear path, but you may have an opportunity that comes by and it's worth considering. Following your passion. You won't know if you don't ask. Don't be afraid to think big. Align yourself with the people that are passionate and enthusiastic about what they do. We didn't talk about negotiation, but whenever I negotiate, even with folks that we're planning to hire, I like when they come to the table and advocate. I think that's good. And seeking professional fulfillment and trying to lead a balanced life. So I'll leave you with some final thoughts. Successes come, failures come and go, but curiosity lasts. This is my daughter who's intensely curious. And successes are fleeting, failures are fleeting, but the curiosity is what really keeps us going. Fighting for ideas while we treasure people. So it's good to continue to advance our initiatives as we treasure the people that we work with. This is important too. I mean, sometimes it looks so straightforward, but our careers are not straightforward. It's not a ladder. It's a jungle gym. You know, you go one direction, find it's not working, you go a different direction. And then along these lines, I mean, when I was first starting out, I thought getting from point A to point B looks so easy. My mentor, she's, amazing. She made it look so easy. You read something, you have an idea, you network a little, and then you have success. And in actuality, that's more compressed here at the beginning of the timeline. And you work like crazy, you fail a bunch of times, and then through the circuitous route, you actually realize your goals. So just important to know that that's what happens and what it looks like. And then I'll leave you with this concept of ikigai. And I'm sorry if you've heard this already from me, but I really feel strongly that this has allowed me to, as I go along, continuously reevaluate your reason for being. So, what the world needs, what you love, what you're good at, and what you can be paid for. So the confluence of that is ikigai. And so continually assessing, seeing, are you doing what really is fulfilling is basically what it comes down to. And for me, it's mentoring, it's sponsoring others, it's facilitating careers and advancing meaningful science. So I hope you have, especially for those who are learners and early in career, learned that the path in academic medicine is not a straight line. It's a journey of purpose that's shaped by persistence and a journey of persistence expanded by possibility. Sorry for the alliteration there. My hope is that sharing some of this, my path will help illuminate yours. So thanks. Thanks for your attention and happy to take any questions. Yeah. So Dr. Lyles is asking, how can we instill resilience? As we're entering, the canyon of despair, as we saw on the research map, it's challenging. And I think what's at least helped me is talking to my mentors, recognizing I'm not alone. Others have gone through the same rejections. If you're passionate about it, then hopefully that will keep you going. And then leaning on peers. Leaning on my peers was really helpful too, because you can let off some steam and just talk about it, and again, just knowing that you're not alone. And the mentorship is and if you're in a community where you've lived science and gone through the path, then that's just, it comes with the territory. And it's challenging. And I think those are just some ways that you could try to get through it. Yeah, no, that's a very good question. So Dr. Altermeyer is concerned about my sleep. I can assure you that I practice what I preach, and I do get 7 to 8 hours of sleep a night. It's important to me, and I'm pretty cranky if I don't get that amount of sleep. In terms of what can we do to address the bottleneck in terms of diagnosis and treatment of sleep apnea, I think as the technology space is really booming in terms of more efficient diagnosis of sleep apnea. So I think if we can get, of course, there's all these wearables out there. There's question as to their validity. But if we can get to a point where we have valid technology that can accurately diagnose sleep apnea, that I think will help. our workforce is, the pipeline of sleep physicians. I think it's actually there. Do we need to bolster that? Do we need to look at our clinical pathways and just, again, figure out where the bottlenecks are to address things? So I think it's probably a multi-pronged approach. It's a good point. Yeah, so question is primary care physicians, can they order sleep studies, and can we have some more efficient way using AI to glean the diagnosis? And yeah, I think that's possible. Maybe a stepped care model, like where if it's more straightforward, high pretest probability, not a lot of comorbidity, and really, then doing the sleep study, you can get somebody on treatment. However, they have more complex comorbidity that's going on along with suspected sleep apnea, or if you're thinking central sleep apnea or other comorbid sleep disorders, then kind of going to the sleep specialist and sort of in a step care kind of model.